Hello everyone, and welcome to this audio podcast. In this series, the LabTronix series, as part of the Ballistix Edition. This is an RPSG and KNAS collaborative, an RPSG and KNAS collaborative in line with the Storm Ballistix production. This is the Shientist, and this is an audio a podcast in relating to renal replacement therapy, wherein I'm going to provide a sort of an overview around RRT. So to begin with, one of the main forms of RRT is renal transplantation. So renal transplantation is a major advance of modern medicine, which generally provides a high quality of life life years to patients with irreversible renal failure or renal disease, and improves long-term survival compared to sort of other forms of renal replacement therapy. Renal transplantation generally is the treatment of choice for patients. For a treatment, is one of the sort of main treatments of choice for patients in approaching, for example, end-stage renal disease or ESRD, because of sort of the sort of cost benefits, the cost advantages versus other forms of renal replacement therapies as well. Renal transplantation is also a treatment choice for those approaching not just end-stage renal disease but also CKD stage 5. It has been limited by immunological rejection, adverse effects of sort of immunosuppression or immunosuppressant agents, and also when there can be a relative shortage of available organs. Donor kidneys can be from a living or cadaveric donor, and living donors can be through a directed donation, a non-directed donation, or an exchange sort of program in which one donor kidney is sort of exchanged with another more compatible kidney in this context. And deceased donors or cadaveric kidneys are designated by a kidney donor profile index or KDPI, ranging from anything from 0 to 100%, and a KDPI scoring system integrates factors including a KDPI scoring system integrates various factors as well. Now, in line with this, a KDPI also predicts the life expectancy of a renal transplant or kidney transplant, with lower scores predicting longer graft survival as compared with higher scores. Most kidneys are from individuals declared as cadaveric, from at least from a cadaveric perspective, as brainstem dead, designed as a donation after brain death. And another category is donation after circulatory death, where renal transplantation from donation after circulatory death donors carries and increased can carry an increased risk for delayed graft function compared with kidneys from donation after brain death donors. So there are some advantages, obviously advantages and disadvantages. Advantages of early transplantation include where renal transplantation from a live donor or deceased donor generally provides the the best sort of outcomes amongst available modalities in and around different forms of renal replacement therapies. In most nephrology practices, educational efforts regarding modalities of surrounding renal replacement therapy is instituted in around CKD stages 3 or early CKD stage 4. This should be accompanied by a referral for transplant evaluation in early CKD stage 4, and by the time the estimated glomerular filtration rate declines less than 20 mL per min, where appropriate candidates should have been identified and placed on a waiting list. And again, there's works going back going back and documented, and the full citation at the bottom of this slide. And also in line with this, early transplantation is associated with positive patient-reported outcome measures or patient-reported outcomes in line to both where there's advantages for the patient and in context of prognosis and graft survival. And it is transparent, or is clear, that transplants performed preemptively, for example, reduce the frequency of costly complications such as delayed graft function, acute rejection, and allograft failure. And the KDOQI guidelines recommend that patients with estimated glomerular filtration rate less than 30 mL per min be prepared for a form of renal replacement therapy, and that can be, for example, hemodialysis, peritoneal dialysis, or transplantation, but do not describe, for example, the preemptive transplant option in detail as one of the main advantages. In context of aligned to this is also immunosuppression. So at the time of transplantation, as a form of renal replacement therapy, patients are treated with induction therapy. So there can be T lymphocyte depending agent or an interleukin or IL-2 inhibitors, for example, basiliximab, which is a part of the apart from being an interleukin-2 inhibitor, also known as a monoclonal antibody. Maintenance immunosuppression is initiated in hospital settings and continued for the life of an allograft. Treatment is started before or after the time of transplantation. And in the early weeks and months post-transplantation, the transplantation center or the nephrology department, in this context, generally monitor and adjust levels of immunosuppression therapy in line with the pathology and what are known as sort of the biochemistry departments within pathology. Target levels and are influenced by side effects and where there can be infection and malignancy complications in renal predispositions and transplant duration. Agents are used in combination to achieve sort of sufficient immunosuppression while minimizing the toxicity associated with agents. And the higher risk for acute rejection is highest, for example, in the first 3 months post-transplant. High doses are of immunosuppression are used during in this duration. Any immunosuppressive medication or regimens generally result in substantially better patient reported outcome measures than other forms of renal patients on where they may be on other forms of renal replacement therapy and other sort of regimens in accordance to sort of medication regimens as well. Immunological and non-immunological factors in related to transplant outcomes. So there can be economic barriers, there can be biological, immune, genetic, and metabolic barriers. There can be pharmacological issues. There can be comorbidities. time and initiation to forms of renal replacement therapy, including hemodialysis, donor and organ characteristics, tolerance and adherence, and of course access to particular areas of particular aspects of healthcare. Monitoring post-transplantation, regular monitoring of renal function is generally required throughout the life of a transplanted transplant. After transplantation, renal function is monitored. Can be monitored anything from twice weekly for a month, with an increase in frequency of monitoring over at least the first year post-transplant. Standard practice is monitored. Standard practice is to monitor laboratory and reference ranges indicative of transplant renal function, no less than sort of every 3 months, for example, at least in the early phases post-transplant. So I mentioned in one of the previous audio podcasts around serum creatinine and acute illness, especially a viral illness or urinary tract infection. It is wise to check serum creatinine concentration after the illness, because of generalized immune response can trigger sort of a rejection episode. And the rule in monitoring transplant recipients is that 20 to 25% increase in serum creatinine concentration above baseline requires sort of attention. And gold standard assessment of increased serum creatinine concentration again is to potentially prompt the requirement of a renal biopsy. And in another sort of follow-up audio podcast in this series, I do talk a little bit around renal and surgery and biopsies in this regard as well. In relating to cellular rejection, cellular rejection is perhaps one of the most likely or probable issues that occur in early weeks to months post-transplant, or potentially later, especially if immunosuppression is reduced. Cellular rejection commonly presents a symptomatic increase in serum creatinine, and symptoms of rejection including fever, graft tenderness, oliguria, also known as where individuals may have either an complete inability to void, or where there can be a sort of a sensation, but the bladder could be the bladder can potentially be compromised, and along with other complications. Treatment of rejection is dependent on the severity and the degree of background chronicity as well. A little bit about humoral rejection. And so humoral rejection is generally as a rare occurrence, but can develop within seconds of implantation of a transplanted organ as a result of high levels of antibodies against antigens on the endothelium of glomeruli and microvasculature of the donor kidney in this context. And humoral rejection can lead to necrosis, where there's full-blown ischemia, and also where there can be generally can generally be cell death around the transplanted organ. And the detection of donor-specific antibodies, also known as DSA, and sophisticated cross-matching techniques generally have eliminated humoral rejection and in line to necrosis, and so generally in the post-transplant phases now, it's more related to cellular mediated rejection. more so than humoral rejection. But just also suffice to say that acute antibody-mediated rejection, or AMR, occurs within the first weeks to years post-transplant, as per mentioned. But the most common mechanism underlying acute antibody-mediated rejection, or AMR, is an antibody response that results from previous antigenic exposure, such as, for example, pregnancy, blood transfusion, or prior transplantation. And some aspects around best practice and the outcome benefits of preemptive transplantation do not seem related to native renal kidney native glomerular filtration rate at the time of surgery. The glomerular filtration rate at the time of transplantation exerts little influence on estimated glomerular filtration rate of the allograft. An appropriate timing of preemptive transplantation should be individualized based on patients' variables, including rate of progression of CKD, symptoms attributed to CKD, management of comorbidities, donor and candidate convenience as well. So I want to say thank you for tuning in on this audio podcast surrounding renal replacement therapy, and this slide here highlights a few acknowledgements in the co-development of this sort of slide set with colleagues between academic institution and organizations known as the Renal Patient Support Group, the RPSG, and the Kidney Disease and Renal Support Group, or KDARS for kids. Once again, this has been an audio podcast in the series, the LabTronix series. This has been the Shientist, and it's been another Storm Robotics production. Thank you for taking the time to tune in on this.